our moderator for this evening. Okay. Our moderator for this evening is a General Pediatrics, a diplomate of Philippine Pediatric Society. She is also the Medical Officer 3 of Pediatric Department at General Emilio Aguinaldo Memorial Hospital in Trece Martires City, an active consultant of MB Santiago Medical Center, Trece Martires City, and also in Gen 3 Doctors Medical Center and Hospital. She had her residency at De La Salle University Medical Center in 2005 to 2008 and her internship at De La Salle University Medical Center 2003 to 2004. She is also a member of Philippine Medical Association and Philippine Pediatric Society, Inc. Let's give it up for Dr. Arsen Buenviaje Santos. Verna? Andiyan ba si Doktora?
Nandito si Doktor.
Ayun. Doktora. Medyo nagka-problema yata si Doktora, no? Nawala ulit si nawala si Doktora, no? Nawala nga ba? Nawala siya, no?
Nawala, boss.
Okay, nawala. Sir Zoren?
Yes, sir.
Maybe you can introduce our speaker? Since nawala kasi si Doktora, baka medyo nagka-problema yung kanyang internet.
Sure.
Okay. Sige, flash ko lang po. Okay, Sir Zoren?
Good evening, doctors. Good evening, PPS-STC. So we would like to introduce to you our guest speaker for tonight, Dr. Sarabeth de Castro, General Pediatrics, diplomate, Philippine Pediatric Society. She is a diplomate of Philippine Society of Pediatric Gastroenterology, Hepatology, and Nutrition. She has clinical training in the postgraduate medical intern at De La Salle University Medical Center, resident physician at the Department of Pediatrics, De La Salle University Medical Center, fellowship training, Pediatric Gastroenterology, Hepatology, and Nutrition in Philippines Children's Medical Center, Philippine Pediatric Society Special Board Written and Oral Examination on March 2011 and March 2013. So, Philippine Society of Pediatric Gastroenterology, Hepatology, and Nutrition, Board Examination, March 2017. Our guest speaker is a member of in the organization, Board of Trustee in the Philippine Pediatric Society, Southern Tagalog Chapter, Secretary in the Philippine Society of Pediatric Gastroenterology, Hepatology, and Nutrition, member of the Philippine Medical Association and Cavite Medical Society, also a member and diplomate of Philippine Pediatric Society and Philippine Pediatric Society Southern Tagalog Chapter. She is also a member and diplomate of Philippine Society for Pediatric Gastroenterology, Hepatology, and Nutrition. So once again, let's give it up. We give it up with Dr. Sarabeth de Castro. Yeah.
Hello and good evening, sir. Thank you, sir, for for that introduction, ha?
Yes,
I
doktora,
think
medyo nagka-problema yata si Doktora Arsen, pero hindi natin may iwasan talaga lalo na't virtual tayo eh.
oo nga eh. Oo,
Yes,
sinabi
mamaya
mo pa.
babawi yan si Doktora Arsen.
Oo, sige. But
Thank you,
for a
doktora.
while, thank you for a while. Let me share my slides. Wait lang. I hope everyone is doing well, and we've been seeing lower cases of Omicron the past few days. So sana tuloy-tuloy na. So can you see, Sir Arnie, my slides now?
Yes, doktora.
Okay. So again, good evening, everyone, and thank you, Sir Zoran, for that wonderful introduction. I do hope that Dr. Santos can be with us later in the question and answer. Well, good nutrition is very important in achieving normal growth and development. Nutritional assessment is actually the first step and an integral part to take care or to care for every pediatric patient. Routine screening measures for abnormalities of growth, and this should be performed in all pediatric patients. And I am here tonight to discuss with you nutritional assessment in infants and in children. Our main objective for today is that to discuss nutritional assessment in terms of anthropometric measurement. So probably this could be a way or a form of review for everyone. So an assessment of nutritional status is very essential in pediatric healthcare, both for a well and a sick child. It is a product of many interrelated factors. So you have food, care, and even environment. It is then highly important that we catch and identify malnutrition among our patients. Z-score and percent classification of nutrition or nutritional status are equally efficient in predicting malnutrition. So acute malnutrition, when we talk about this one, it can be classified as moderate or severe. And we can use the weight for height or the weight for length, the mid-upper arm circumference, and the presence or absence of edema. But we have to be reminded that the mid-upper arm circumference can be used to identify severe acute malnutrition, but can only be used among children 6 months to 5 years of age. Now, moving on, the best way to assess or for us to assess nutritional status is with the use of your WHO growth chart. As defined, under weight, it is the weight for age that is below -2 standard deviation. On the other hand, you have stunting if the height or the length for age is below -2 standard deviation. Wasting is the weight for height or weight for length below -2. And on the last part, overweight is weight for height that is above +2 standard deviation for our children ages 2 to 5 years of age. And I have to reiterate, the best way to assess the nutritional status is getting your weight for height or weight for length and the height or length for age, because this will signify wasting and stunting. On the other hand, the most commonly used index for nutritional status would be weight for age, but it has very limited clinical significance because it will not differentiate wasting from stunting. Okay. Looking at this slide, stunting refers to a child that is too short for his or her age, and you have failure to grow both physically and cognitively. Wasting, on the other hand, refers to a child that is too thin for his or her height. So you have to consider the weight for height or weight for length. And usually this could result from a rapid weight loss or failure to gain weight. And lastly, we've been seeing trends of these overweight and obese individuals, especially children. This would refer to a child that is too heavy for his or her age. Now, the task that needs to be performed in nutritional assessment will include the following. So we have to remember this 4 tasks. You have to measure using the weight, the length, the height, and calculate for the body mass index. The next is you have to plot in the appropriate growth charts, specifically the WHO growth chart. And then interpret. We have to know how to interpret the growth indicators. And lastly, we have to help in addressing the possible causes of poor growth that could be present in that child. And in order for us to assess this growth and anthropometrics that we should have an accurate equipment, an accurate measurement techniques, plus an accurate reference standards. So we have to follow the same standards. Now, let us start with the following anthropometrics. Specifically, we would discuss on weight, length and height, BMI, mid-upper arm circumference. And this will help us in determining the nutritional status of our patients. And let us briefly discuss each one of them. So starting with the weight, we have to have a proper technique in measuring weight. So if you want to measure weight, it is recommended that you weigh child using a scale that has the following features. So it has to be solidly built and durable, electronic or digital in reading. It can measure up to 150 kilograms. It can measure a precision of 0.1 kilograms, and it allows tarred weighing. So what is this tarred weighing? So in tarred weighing, this means that the scale can be reset to 0 with the person just being weighed still on it. So for this diagram in the first picture, you see the mother's weight alone. So the next, it can be reset to 0. So while that person remains on the scale, the child is given to her, and the child's weight would actually appear on the scale. So that's what you call tarred weighing. The advantages of this tarred weighing is that, of course, you don't need to subtract the weights to determine the child's weight from the mother's weight. You lessen also the risk of error, and the child likely to remain calm because it was held, or he or she was held in his or her mother's arms. So just some examples of weighing scale through, though we can't use this to check for the tarred weighing. So again, if you want to check for tarred weighing or get that technique, you have to reset that, or you can reset that weighing scale back to 0. So for a child less than 2 years of age or unable to stand, you use tarred weighing. While for a child for 2 years and older, you have to weigh the child alone if the child can stand on his own. So just for babies, on the other hand, they should be weighed naked and wrapped in a blanket, of course, to prevent hypothermia and to keep them warm. While for older children, we should remove all but minimal clothing, such as your underclothes. So moving on, we are done with weight. Moving on with the length. Measuring length for children less than 87 centimeters, or probably around 3 feet, or too weak to stand, we have this measuring device with fixed board at one end and a movable board on the other end. So you need a measurer, a person that will measure, and the one that is an assistant will be your assistant. So the assistant will hold the head of the child, hands cupped over the ear, and the head against the board. So the child, while lying flat, the measurer actually holds the knees, and with the legs straight and feet flat, it will be against the movable plate. So just an example for this one, if this is the movable plate and the child's feet is on this side, so the child's length for this one would be 66.3 centimeters. So you can move the board if you are the measurer. So in general, if you want, or if you have a child that can stand or who are taller than 87 centimeters, then probably you can use this equipment. You have a movable board at one end, this one, and the child standing with his body flat against the wall. So the feet flat against the foot piece, and the arms comfortably straight on the side, shoulders level, and you can measure the line of sight perpendicular to the base of the board. So in general, standing height is about 0.7 centimeters less than the recumbent height. So just again, an example. If you have this child's head against this side, the movable headboard, then the child's height, as an example, would be 94.2 centimeters. So we have to be careful. We have to be accurate in getting the weight or the height or the length of these children. Okay, in some instances, on the other hand, if a child less than 2 years old that will not lie down for measurement of length, sometimes we can measure the standing height and probably add 0.7 centimeters to convert it to length. So for example, the standing is 80 centimeters, you add 0.7, so the actual length would be 80.7. On the other hand, kabaligtaran naman, if the child that is less than 2 years and cannot stand, or more than 2 years but cannot stand, you can get the recumbent length and subtract 0.7 centimeters to convert it to length, to height. So just an example, 95 as the actual, the 95 the length, and you subtract 0.7 centimeters, so you get 94.3 centimeters to get the actual height. This slide is very useful for our patients who have cerebral palsy, or those probably who have seizure or contracted lower and upper extremities that cannot stand alone or straighten the upper or lower extremities. So we can do the following techniques to estimate the length or the height by using the knee height or the upper arm length. So these are the formulas that can use if you have the knee height, and if you have the upper arm length, you can use this one. In some references, you would see this estimation of stature. Actually, it is almost the same with the previous formulas that I have shown a while ago. It can also estimate the stature or the height or length, and you have to get the upper arm length or the tibial length or the knee height as well. So this was taken from North American Growth in Cerebral Palsy Project and the prediction of stature using the knee height. So you can use either of the formulas shown in this slide. Okay, we are done with the weight, the height, the estimation of stature using knee height or upper arm for some special considerations. Now we proceed with determining body mass index. This is an important in assessing nutritional status, and it is a good measure for adiposity. So for us to compute for the BMI, it is computed by weight in kilograms divided by length or height in meters squared. So we have to convert our height from centimeters to meters. So just an example, if you have a weight of 16 kilos, height of 105, you convert to meters, then it's 1.1. So if you divide 16 from 1.1, then your BMI is 14.5 BMI, kilogram per meter squared. So we have to round the BMI to 1 decimal place. And probably we can use to assess adiposity or overweight and obesity. In assessing those patients, we can use the BMI or BMI for age. Okay. For the mid-upper arm circumference, this is a quick measure of malnutrition, specifically your severe acute malnutrition or moderate acute malnutrition. This is very useful, especially in community settings where we don't have access for weighing scale. So, but just a review again, MUAC is only used for children 6 months to 5 years of age. So we cannot use this parameter for less than 6 months of age. So just a few steps to review. We have to first locate the tip of the shoulder. So tip of the shoulder and tip of the elbow. So you place the tape from the shoulder to the bend of the elbow, and then you mark the midpoint. From that midpoint with the correct tension, in which the tape is not too tight or too loose, then you measure the mid-upper arm circumference. So in interpreting your mid-upper arm circumference, this is a good table to interpret your MUAC. So if you have a MUAC of more than 13.5 centimeters, the child is well nourished. If it's between 12.5 to 13.5, then probably at risk for acute malnutrition. 11.5 to 12.5, it has already moderate acute malnutrition. And lastly, if it is less than 11.5, then probably this child can be classified as to having severe acute malnutrition. Once we are already equipped with getting the accurate anthropometrics using accurate techniques, we can now proceed in plotting the parameters to the growth chart. And the most appropriate, again, is using your WHO growth chart. So let us try this example. We have a 6-week-old and weighs 5 kilograms. So for the weight per age, 6 months in this axis, and then you plot the 5 kilograms, which is exactly in the green line. So this green line would actually represent normal or within the median of the standard deviation. So this has normal weight. Weight for age, again, I have to emphasize that can be used as a nutritional status index, but it has limited clinical significance, but because it will not differentiate us from classifying wasting and stunting. So what we can use, it can be available, or the weight per age can be used in case we have unavailable equipment to measure the height or length. So interpreting this growth chart, if the weight per age of your patient falls within below -2, then it is classified as underweight. But if it's below -3, it is already classified as severe underweight. On the other hand, if it falls within this green shaded area, then it can be classified as normal weight per age. And lastly, if it's above +2, then it can be classified already as having overweight. So look at that shaded area of light red. Now, we measure height per age or length per age for stunting. So let's try to see the differences when plotting the height per age or length per age. So now focusing first on the normal. So this shaded area of green would actually represent the normal or no stunting. Above +3, then we have to consider probably some endo problem for these patients. If it's below -2 but equals -3, then your patient is already stunted. And lastly, if it falls within the gray shaded area or below -3, then it is considered already to have severe stunting. So I hope you were able to get that one. Now, how about weight for height, which is significant in measuring wasting, or probably overweight and obesity as well? So looking at this shaded area of pink, if it's below -2, then you classify it as wasted. So we have to check below -2 until equals -3. So that's still wasting. If it falls below -3 or -3, then you consider that patient as having severe wasting or severe malnutrition already. If it's within the green shaded area, it's normal. Okay, so that's still normal in the green shaded area. So for example, if your weight for height falls exactly or equals to -2, it is still considered normal. If it's below -2, dun lang magkakaroon ng wasting. And the orange shaded area, on the other hand, is the possible risk of overweight. So it's above +1. And if you have above +2, then you consider that already as having overweight. While if it's above +3, you consider that to be obese already or presence of obesity. So that's it. How about BMI for age? Again, I have to emphasize that BMI for age can be used to measure wasting or also overweight and obese. So both your BMI and the weight per length can be used for these parameters. So starting off with the green line and this arrow. So the green line and up to the -2, it is still normal. Up to +1, it is still normal. If it's below -2, then you have thinness or wasting. And if it's below -3, severe thinness or classified already as severe malnutrition. On the other hand, if it's above +1, it's considered to be overweight. And if it's above +2, it is already considered obese or presence of obesity. I have to clarify this one. If we are to compare overweight and obesity from 5 to 19 years old and 2 to 5 years old. So again, tandaan muna natin, for 5 to 19, above +1, overweight. Above +2, obese. Okay? For 2 to 5 years old, above +2 ang mako-consider na overweight. And it is only above +3 mako-consider natin obese. So balikan natin ulit. So if it's above +1 ng 5 to 19 years old, considered as overweight. Above +2, definitely above +3, obese na siya. But BMI for age na 2 to 5 years old, if it's above +2, saka lang siya overweight. Above +3, then we classify as obese because you have this as risk for overweight. So this is ito yung isa sa mga clue in the WHO growth charts in which minsan nami-miss out natin. So we have to remember this when talking about adiposity or BMI for ages 2 to 5 and 5 to 19 years of age. Okay. So just a reminder, in plotting in the growth chart, if the point is plotted exactly on the Z-score, sakto sa linya, then it is considered less severe category. So meaning if it's equals -2, still normal. If equals -3, then stunted or wasted lang. Like here, if the Z-score, weight per length, is equals -2, then still normal. Pero if it's below -2, then you consider that as wasting already. So again, just an example in practicing or reviewing our plotting in the WHO growth chart. So a 1-year-old, 7.5 kilograms. So you have below -1, but still not below -2, so still considered to be normal. Now, to differentiate moderate acute malnutrition from severe acute malnutrition, if it's below -2 and equals -3, then it is considered to be moderate acute malnutrition. But if it's below -3, definitely it is considered as severe acute malnutrition. So lahat ng plotted points below the -3, you consider that as having severe acute malnutrition. Now, it is important to consider all growth chart to check if any will show problem, but focus should be given again in the weight per length or weight per height and length or height per age charts for us to identify stunting or wasting. So stunting, the length per height or height per age that is below -2 implies a long time or probably the child received inadequate nutrients to support normal growth or suffered from repeated infection. The weight per height or the weight per length or wasting is a reliable indicator, even if age is not known. So wasting will signify a recent severe event, probably a reduced food intake or an illness that causes severe weight loss. And lastly, BMI, that is similar in a manner for weight for height or weight per length, and both indicators would help us assess if the child has excessive weight in relation or relative to height or length of that child. This slide, just to review and differentiate again, moderate acute malnutrition, if you have the Z-score between below -2 and equals -3, and severe acute malnutrition if the Z-score is way below -3. So that's the classification, WHO publication in differentiating moderate and severe acute malnutrition. So we also have to take note in every child visit to our clinic, and we have to worry if the child's growth line crosses a Z-score line. So we have to check probably if we are missing something in this child's growth. If there is a sharp incline or decline in the line of the growth chart. And of course, if the growth remains flat, this may signify problems or growth problems and probably attention to look for the cause is warranted. Now let's try to plot the weight and the length of this patient. So we have Alex, a 5-month-old, weight of 7.5, length of 65. So let's try to assess the nutritional status. So the weight per length, again, above 0. So you consider that as no wasting. If the length per age, it's below the green line or 0, still no stunting. So the nutritional status, normal, no wasting, no stunting. Second case, we have Anna, 7 months old, 5.7, 65 centimeters. What is the nutritional status of Anna? So the weight per length is below -2, so wasting. And the length per age is below 0, so no stunting. So the nutritional status for Anna is wasting, no stunting. Next, we have Ina, 11 months old. So the weight of 4.5 and 63 centimeters. Parang sa first look pa lang alam na natin, weight of 4.5 in an 11 months old. So looking at this graph, weight per length, below -3 or -3, severe, signifies severe wasting. And the length per age is actually below -3, so signifies severe stunting. So the classification for this patient will be severe acute malnutrition. This, based on the WHO standards, the following are the diagnostic criteria that we can use for acute malnutrition in children. So just to differentiate, in severe acute malnutrition, if you have the weight per height that is below -3 z-score, if you have the mid-upper arm circumference, again, below 11.5 centimeters, and if you have the presence of bilateral peaking edema, be it grade 1, grade 2, or grade 3, it is already considered as having your severe acute malnutrition. On the other hand, it can be classified as moderate acute malnutrition if you have the weight per height that is in between or below -2, but equals -3 in the z-score. And of course, if you have the MUWAC in between 11.5 to 12.5 centimeters. So that patient can then be considered as having as moderate acute malnutrition. Edema, as part of classification of your severe acute malnutrition, should be assessed. It can be done, as we all know, by pressing both feet, and if you left it for 3 seconds, and if this remains, then probably you have edema. So it can be classified as mild, moderate, severe. So mild if both feet, moderate if it involves lower legs, lower arms, and generalized if it's up to the face, upper arms, and legs also. So this is considered a severe form of your edema. And the presence of edema, be it grade 1 or be it mild, moderate, or severe, will definitely signify the presence of severe acute malnutrition. Now, evidences showed that the mortality risk of children who are underweight is even at greater risk. Child who suffer from growth retardation could be due to poor diet, and you could have recurrent infection and probably at risk for illness and death. So we have long-term nutritional deprivation that would also result in delayed mental development and even poor school performance and reduced intellectual activity. And lastly, for obesity, which is in increasing trend nowadays, probably addition could be because of the pandemic, less physical activity. It has high probability of leading to health consequences such as diabetes and cardiovascular diseases later in life. So what can we do about this? Actually, these are additional slides that will help us probably address or in a way enlighten us on how we can do or how we can act after assessing the nutritional status of our patient. The FNRI goal is to start good nutrition, especially in the first 1,000 days. According to FNRI, start right is the right start. So we have to make sure that we start right by getting the right nutritional status. And we wanted to improve the nutrition, especially by 2030. The target is to end all forms of malnutrition, underweight, stunting, wasting, and even your overweight and obesity. We wanted to reach the target to decrease the prevalence, again, of all forms of malnutrition for children under the age of 5 years old. So just to mention and reiterate, the first 1,000 days is the critical window of opportunity for us to provide the good start for proper nutrition. This starts from conception up to 2 years of age. Nutrition of pregnant moms should be well supported, as well as providing optimal nutrition for infants through breastfeeding. We have to be reminded also the guide on complementary feeding that starts at 6 months. And of course, the transition to family food of a growing child. So we have to address these areas in which we could have good nutrition later on. So one way to end all forms of malnutrition is to, of course, know the recommended energy intake. This recommended energy intake was taken from the PDRI, from FNRI 2015. So this is the latest. So these are the reference intakes that provide guidance on the nutrient needs for individuals across different stages. So focusing on this red font, this one, kasi for us pediatricians, we have to focus the per kilo recommended energy intake, right? So this table is the recommended intake for all age group, but focusing on the red font, male and female side. So this will give us the estimate recommended energy intake per kilo of this age group. So you can compute, like for example, a 5-month-old that is 6 kilos, 6 times 95. So that will be the estimated energy intake per day of your patient. So and so on and so forth. So for adults, for us, we can also have this guide as to our energy intake. So probably for us females, ayoko nang sabihin yung age. Sige, tingnan na lang po natin yung table. Okay. So that one is the latest. And then moving on to the macronutrients. So with regards to the macronutrients, I would always say this, it has to be within the acceptable distribution ranges as recommended by FNRI seen in this table. So protein, you have this range. Fat, you have this range, and carbohydrates. So again, this is the latest that was published or given by FNRI in 2015. So we can have this table as a guide for us in providing the right amount of macronutrients. Why is this important? Because of, we've been hearing about a lot of fad diets, a lot of different diets that will probably focus on increasing fat, lowering carbohydrate, increasing protein, lowering fat. Again, in order for us to have a good nutrition, we have to have this balance percentage, or we have to follow this macronutrient distribution. Not just for our patients, not just for children, but for adults as well. For children 6 months to 2 years old, the different food groups should be well represented in the diet. Previously, we know that even if the FNRI, the minimum dietary diversity that was recommended was 4 out of the 7 food groups. However, just to mention, in the latest 2021 indicators for assessing infant and young child practices, breast milk was actually included in this food group na. So, and they increased the cutoff to 5 out of the 8 groups. So plus 7 groups or food groups plus breast milk. So parang nangyari, it can be 5 out of the 8 food groups. So the dietary diversity from this WHO latest recommendation in indicators for assessing infant and young feeding practices actually improve linear growth in young children. And sometimes if you have lack or less diversity in the diet, it may risk these infants for having micronutrient deficiency, which could have later on damaging effect both in the children's physical and cognitive development. So another guide that we can use, we have the Pinggang Pinoy Healthy Food Plate for Filipinos. So part of the healthy diet should be focused on proper representation of your macronutrients. So a healthy diet that is sound, that creates a sound, stable, and balanced intake should address all the entire nutritional spectrum, specifically the macronutrients. So you have the Go, Grow, Glow equally represented in this Pinggang Pinoy. And what is good with this Pinggang Pinoy is that they can serve as a guide. They have a sample one-day meal plan for kids. So they have here specified here the options that you can give for Go, Grow, and Glow food. So Glow, they separated veggies from fruits. And they also have this sample one-day plan at the back. So a fried egg, kamote, tomatoes, rice, and banana. So at least you can have guide depending on the age group of your patient. So this is actually a good leaflets probably that we could have in the clinic and show to the mothers and to the kids as well. Makulay din kasi, so I think mas makikita nila regarding the importance of having proper diet and good nutrition. And lastly, with regards to micronutrients, there are a lot or more than 40 nutrients that could be essential to health, and increasing micronutrient intake could be supported through the dietary diversity. So you have to have different choices of food in the different food groups. And just to mention, calcium, magnesium, and phosphorus may have prominent roles in processing energy and transport of metabolites. Iron is very critical for the generation and functioning of proteins. And the AAP recommendations regarding iron or elemental iron to start at 4 months of age, and for preterm infants starting at 1 to 12 months of age. Okay, in summary, before I end this discussion, nutrition screening and assessment again should be an integral part of our routine care. It is important at the primary care level and involve many anthropometric measurements. But we have to again start right. Anthropometry involves the following tasks. So we have 4 tasks to complete. We can measure, we have to plot it right, we have to interpret it, and we have to act and look for the possible cause if growth parameters or growth problem is present. Anthropometric measurement, in particular, weight, length, MUWAC, along with the presence of bilateral pitting edema, are most important indicators in identifying acute malnutrition. Well, healthcare providers such as us play a very important role in the identification and, of course, management of your severe acute malnutrition. We have to have an adequate, a proper, and balanced nutrition that could be provided on child's diet to prevent malnutrition. And the first step, again, is to end all forms of malnutrition should start with the right nutritional assessment. Again, please join us in fighting against malnutrition or all forms of malnutrition. Thank you again for listening, and have a good night, everyone.
Thank you, Doktora. Thank you, Doktora Sarabeth, sa pag-share po ng ating knowledge regarding po sa topic. And now, again po, we would like to welcome po our moderator, Dr. Arsen Buenviaje Santos. Doktora.
Hello, magandang gabi po. Hello, Dr. De Castro. Ay.
Hello. Good evening, Dr. Arsen.
Good evening to all of you. Doktora, meron pong mga nagtatanong dito. Ang unang tanong po, what is the difference between WHO and CDC growth chart?
Actually, before, question ko na rin yan eh. Ano nga bang difference? Di ba? Sa CDC, we use percentile. And in WHO, we use Z-score, Dr. Arsen. But hindi lang doon nagde-depend yung difference nilang dalawa. The main difference probably is the reference for the children in which they try to get the median values of the Z-score and the percentile. So for WHO, they use or they got the standard deviation by the growth of a healthy children or healthy children population. So that's for WHO. On the other hand, for the CDC, they have a specific population in a specific area. So hindi na classify doon if these are children who are at growth or at optimal healthy conditions. So that is why the recommended by the WHO is to use the WHO growth chart. Kasi mas yung population in which they got the standard deviation in differentiating the median from the moderate acute malnutrition or stunting to the severe acute malnutrition or severe stunting came from those who are growing or healthy children. So I do hope I was able to answer that question. Ma'am Arsen, nandiyan ka ba?
Doktora, naka-mute po kayo, Dr. Arsen. Dr. Arsen, you are naka-mute po. Yan. Naka-mute.
Yeah.
Yan, okay po.
Okay na.
Yes po.
Alright. So, meron po ditong comment si Dr. Rogacion. Weight for length is measured up to 5 years according to WHO growth chart, but should use BMI for those beyond 5 years old.
Yes, agree. Thank you, Ma'am Josie. Thank you, Doctora, for giving that comment. So, for BMI to measure for the overweight, obesity, we can use that BMI growth chart for 5 years to 19 years old. I mentioned about the BMI for age that for 2 to 5 years old kasi baka malito kayo na why is it meron din na BMI for 2 to 5 years old. So thank you again, Ma'am Josie.
Another question from Dr. Versosa. Do we have a formula for ideal weight for age and height for patients 5-year-old and above? Or we use the BMI instead? Yun na nga rin. Sinagot mo na, Dr.
Oo.
Weight for age.
Yes, for that one, Ma'am Arsen, thank you, Ma'am Christine, for that question. In order for us to get the ideal weight, it should be the ideal weight for length or weight for height. So as we plot the height, yung magfo-fall or yung magpa-plot in the green line, that will be the ideal weight for height or the ideal weight for length of that patient. So sana
we get the length muna or height bago weight for length, no?
Yes. So if you want, like for example, we have a height length of 89 centimeters na bata, male, or boy. So we want to know what is the ideal weight. So we plot it in the weight for length na growth chart and check kung saan mag-meet sa green line yung weight and yung height. So that will be the ideal weight for that patient.
Okay, Doctora. Thank you. Sana nasagot si Dr. Versosa. And from Dr. Josephine Ann Alban, how do you plot if the measurement is with decimal points? I think you have to adjust to the nearest line on the graph.
Yes.
Opo.
So you have to siguro round it off, Dr. Arsen, to the nearest whole number.
Yan. Another question. This is a very true to life. From Dr. Holgado, how do we convince parents of our patients that obesity is also a form of malnutrition? Most of them find their chubby babies very cute. What is the best advice to give them?
Okay, thank you, Ma'am Dr. Holgado, for that question. Well, in the WHO, we have this what we call double burden of malnutrition, meaning the different forms of malnutrition exist in the same household, same community. So you have the stunting, you have the wasting, you have even micronutrient deficiency, you have underweight, and you have also overweight and obesity. Well, we can convince probably our patients that obesity is a form of malnutrition because it has a lot of consequences later in life. Most children who are found to be obese or overweight um, as a child would probably have or be maintained as overweight and obese up to later in life or up to adulthood. So we also have to probably enlighten them that this can may predispose risk of having early diabetes, early hypotension, and of course we have the metabolic syndrome. So siguro doktora, we have to encourage and show them na marami rin tayong problems to be encountered or to be encountered if we remain overweight and obese. And I have to agree that ang alam natin, 'di ba, if you have chubby babies, they are cute, but of course, we have to emphasize that we have to have a right and good nutrition. So siguro ang first advice na mabibigay natin, it is quite difficult to manage overweight and obese children in the clinics. But first siguro is we have to model as parents. So we have to tell the parents about it. Number two, we have to remove the unhealthy foods within our home. So hindi lang pwedeng siya yung wala. So we have to support this child. Kung walang processed food, then probably lahat within the same household wala. So we also, most of the time naman, obesity and overweight, if one parent is obese or overweight, probably or most of the time yung bata medyo chubby din. So siguro we have to first check within the household kung ano yung mga kailangang tanggalin. And of course, we have to emphasize also regular physical activities for our children, lalo na ngayon, pandemic. So we have to encourage them to do some short or minor physical activities na para lang medyo meron pa ring activity within their home. Pero mahirap, pero kaya naman. 'Di ba, Ma'am Arsen?
Yes, leadership by example.
Yes, agree.
Doctora, I have a personal question.
Yes.
Is there a role for multivitamin supplements in treatment or prevention of malnutrition?
For the multivitamins are given as supplement for most of our patients, right? But in managing patients with severe acute malnutrition, so we have that 10 steps. The WHO have these 10 steps in managing severe acute malnutrition. So part of the micronutrients that were included in that WHO severe acute malnutrition management is providing zinc and iron plus folic acid plus multivitamins, of course. So siguro in a different discussion, it has, we can discuss yung mga 10 steps in managing severe acute malnutrition kasi there are conditions to consider for starting iron, or how long can we give zinc, what's the dose of folic acid or zinc, and even the micronutrients, the multivitamins itself. So it's part of managing severe acute malnutrition. But again, we have to follow the steps kasi marami yung steps. You have to treat electrolyte imbalance, treat and prevent hypothermia. So marami siya. You have to prevent, basta it has a step-by-step procedure kasi ayaw natin, we are afraid for patients who have severe acute malnutrition to have refeeding syndrome. So, which is nakakatakot. Kaya very careful tayo in managing patients with severe acute malnutrition, especially those with edema.
Tama. Mukhang kailangan ng another lecture para doon. Doktora, may isa pang tanong. If bipedal edema is present, can we automatically label the patient as malnourished?
In the WHO table that I've shown a while ago, yes, if you have the presence of bipedal edema, then probably you can consider a severe acute malnutrition. And of course, we have to assess then, diba? We have the other parameters like checking for the mid-upper arm circumference that would help us classify this as severe acute malnutrition. sometimes kasi Ma'am Arsen, di ba, if patients have edema, this could add up to the weight of the patient. So, baka akala natin mabigat yung weight ng patient, weight per length, but actually, it is way below pala because of the edema. So, we have to consider that also.
Tapos, doktora, pag kumukuha ba ng mid-arm circumference, pwede kaliwa or kanan? Kahit ano pwede.
In the diagrams that I have shown a while ago, they use the left arm. Pero siguro, wala naman siyang strict rule. Basta as long as you maintain the angle in measuring the mid-upper arm circumference from the tip of the shoulder and to the elbow. So you get the midpoint and again, get the mid-upper arm circumference. In some community centers, they have the tape, the mid-upper arm tape. So you can use that. Meron yung marker if it's red, green, or yellow. So, pero if in our clinics, we don't have that tape, we can use the measuring tape in measuring mid-upper arm circumference.
Doktora, nakamute po kayo. Ayan, okay na po. Actually, doktora, makasingit lang ako, no? May nag-direct message po kasi sa akin. Siguro hindi niya lang po napansin. Nakalagay po dito is, when do we refer patient who are persistently stunted despite claims ng parent na matakaw and eating well naman? Tapos, ang sabi niya po is, and to what specialist daw po na dapat i-refer?
Okay. So thank you for that question. So for patients who remains to be stunted, siguro ang first clue natin dyan, if we are plotting the length or the height of that patient in our clinics, makikita natin yung trend eh. So if it remains to be flat or hindi talaga siya nag-i-improve, then probably naiiwan na yung weight niya, then probably we might want to consider problem on stunting or probably baka malnutrition na later on. So the first thing to do siguro is to get or for you to assess clearly if the mother is actually giving the right amount or right food is to ask for the diet, the 3-day diet recall. And then we can compute probably for the caloric energy intake or the expenditure of this child. And then if we think that it is way below the recommended energy intake, then probably kulang talaga. So where to refer if you think that the patient concerns would be probably more on the nutrition side than probably gastro specialist. But if you think that the parent is actually giving the right amount of the food or probably the energy intake per day that was taken by this child is actually enough or good for his or her age, then probably we can also ask help from an endocrinologist. Bakit naiiwan yung kanyang height? So both of the pedia-gastro and pedia-endocrinologist can work hand in hand in managing these patients. So that's it, Sir Arnie.
Thank you very much. That question po nanggaling po din yun. Follow-up question po yata ni Dr. Versosa, Christine.
Okay. Thank you,
po.
Dr. Versosa.
Dr. Arsen. Dr. Arsen. Ayan. May question po ulit yata tayo, Doktora.
When will an FGA infant delivered at 37 weeks with a weight of 1.9 kilo at birth be able to catch up? At 2.5 years, it will weigh 10 kilograms.
Si Doktora, from Doktora De Buque. Thank you, ma'am, for that question. Oo. Actually, I've been seeing referrals from the clinics from other pediatricians regarding the poor catch-up or parang ang hirap bigatin ng weight nila. Then probably, Doktora, this is quite a difficult question. For me, I think we have to consider a lot of problems or we have to consider like if we are giving the enough recommended intake for this child. What else? Siguro the caloric intake, we have to consider that, and look at the other steps siguro in managing yung meron ba tayong ibang problems that would probably add up in poor weight gain for this patient. So marami tayo, we have a lot of other factors, Doctora, that we have to consider, especially in trying to catch up the weight or the weight per length or the weight per height or even the weight per age for this SGA infants. Kasi baka mas mabagal yung weight gain nila. Pero it's quite difficult. It's quite difficult, Doctora, to catch up, especially this SGA infants. But we can do that. We can do it in probably considering other factors or other concerns.
Alright. Wala na pong tanong sa chat box.
Doktora, parang may question pa po si Dr. Josie Rogasyon.
Opo.
Ang question po ni Doktora is, in those instances daw po with persistent stunting, get first the mid-parental height to assess the potential height. Actually, hindi pala to question.
Thank you, Ma'am
Yeah,
Josie, for
opo.
that. So parang additional for the question, if you have persistent stunting, you can get the mid-parental height to assess the potential height of that child. So nag-add si Ma'am. Thank you, Ma'am. Thank you also to Dr. De Buque.
Doktora, pagka ba with severe acute malnutrition, pwede nang pakainin ng si ano? Meron ba silang ticket to eat anything?
One of the steps in managing severe acute malnutrition is we wanted to prevent refeeding syndrome. So in refeeding syndrome, the problem is yung kaya pakain tayo ng pakain, we give a lot of food, but the problem is masyado nang mataas yung calories. So we could have electrolyte imbalances that could be problematic later on. So very careful tayo in managing severe acute malnutrition, and we have to consider again the 10 steps. So we have to follow treating and preventing the other parameters in the management of severe acute malnutrition.
And Dr. Arsen.
Yes. I think connection
nawala.
problem, yes.
Yes.
Oo.
Ayan, parang nawala nga po si Dr. Arsen. And I think, Doktora, nandiyan ka ba?
Yes.
Ayun, present pa.
Ayan, nandiyan pala si
Hello.
Doktora. Ayan. Doktora.
Yes.
Ayan. May question pa po yata tayo kay Dr. Amiel Javier.
Oo, from Dr. Javier. Hello?
Opo,
Yes.
Doktora. Nagkakaproblema po yata
Oo
si
nga.
Dr. Arsen. So, I'll just
Oo.
read it na lang, Doktora, no?
Okay, sige.
What will you do to a 2-year-old child who only feeds, ano po yung milk na yan?
Milk.
Opo, milk and refuses to eat. This child is within the normal range in regards to height and weight.
So, difficult child, difficult condition din probably. Siguro kasi this will fall na picky eating na yung child. So, again, we have to restart or start from the beginning. We have to try and give him solid foods. So, 'di ba nga in one of the guide for picky eaters, we can repeatedly introduce one food muna for 15 times, 15 to 20 times, as long as ma-encourage natin siya to eat solid. And then we try again another food and try to give it again to this child as long as kahit paunti-unti. Pero in managing picky eaters, hindi talaga siya, it will not be like a one-time big time treatment or one time, big time na madali natin sila ma-encourage to eat because it's more of a behavior na, na sustain nila from the start that they had complementary feeding probably, or baka complementary feeding was not given from the start. So we can start also by trying if really they don't want the consistency of the food, probably yun munang medyo malalambot. So some would, kasi parang resist having yung mga more of the solid or hard food. So it will be quite a challenge, Dr. Javier, to manage this patients, but we have to encourage and explain to the parents or relatives na kailangan ng medyo mahabang pasensya for this one. Kasi hindi talaga siya madali. So mahirap, pero for those picky eaters, hindi dapat yung parents yung mapapagod. We have to encourage and try until ma-encounter nila or ma-experience nila yung having the taste of the solid food. And probably later on, we could try another flavor para man matry nila din or ma-encourage sila to have a different kind of flavor. So medyo it will take time, pero yun nga, we have to encourage and we have to start from the start, like parang ngayon ka palang magsisimulang magbigay sa kanila ng solid feeding. Pero try until 15 to 20 times, or try with the soft food first. So yun po, Dr. Javier.
Yun. Thank you very much, Doktora, no? So, Doktora Arsen?
Ayan, bumalik na po.
Yes.
Sir, Dr. De Castro. Ito
Apo.
na po ipaalala po ng chapter na sa mga hindi pa po nakakapag-ICPED, sagot na raw po nung ating pre- and post-test.
Oo, Doktora, I think ngayon daw po ang deadline, no po?
Ano ba ngayon? Webes, tama.
Yes, ngayon daw po ang deadline po. So, pasagot na lang daw po, pinapa-announce po ng ating Vice President, Dr. Pontanilla, yung sa ICPED po.
Tama.
Yes po.
Yan.
Ay, yun.
Maraming salamat po. Maraming salamat, Doktora.
Thank you. May question pa.
Ang pahabol na tanong. Use of appetite stimulants, Doktora.
Ako, that's a controversial one, no? Appetite stimulant. Can you comment on the use of appetite stimulant? Again, for appetite stimulants or for the vitamins with appetite stimulant, we have to consider pa din giving the right macronutrient and micronutrient. And of course, we have to again support proper feeding technique or proper nutrition for these children. Kasi if we will just depend on giving appetite stimulant, baka later on wala naman siyang effect. Pero we have a lot of appetite stimulants in the market. So I think we just have to be very careful in giving those appetite stimulants, and we have in the end we have to make sure that we are still giving the right macronutrient and micronutrient for these children.
Ayan, thank you very much, Doktora. And Dr. Arsen, may i-add pa po ba tayo, Doktora? I think nawala na po si Doktora. So, I think, Doktora, that's the last question sa quiz B.
Thank you. Nanalo ba ako?
Yes, I think winner po kayo ngayong gabi, Doktora. So maraming salamat po sa ating moderator and Dr. Arsen Buenviaje Santos, and to our lecturer for sharing your expertise po, Doktora. Maraming salamat po sa pag-unlock sa aming imbitasyon para maging speaker po. And now po,
Thank you.
yes po. Mag-share lang po ako ngayon ng ating mag-proceed na po tayo sa awarding of certificates po. Wait lang po.
Sheep. Why is there a sheep? Bone block. Bone block. That's my luck power.
Good evening, PPS-STC. Join me as we award these certificates of appreciation to our key people tonight.
Sending our warmest gratitude to our speaker, our pediatric gastroenterologist, and also a member of the PPS-STC Board of Trustees, Dr. Sarabeth de Castro.